Welcome to the Kanski lecture series and glaucoma part 2, and in this part we are going to discuss about the ocular hypertension. So ocular hypertension is that whenever you take the IOP measurement, it is in the higher side, but there is no glaucomatous optic neuropathy. So that is known as a ocular hypertension. So, how do you define it? In the general population, the mean IOP is 16 millimeter mercury. Two standard deviation on either side of this provides a normal IOP range for the individual over the age of 40 years of 11 to 21 millimeter. So, mean IOP normal is 16 millimeter, and the two standard deviation on the minimum side and maximum side, which is 11 and 21, are also considered to be the normal in a patient age greater than 40 years. The distribution is a Gaussian with the curve skewed to the right. The upper range of the normal in individual over the 70 years is 23 millimeter mercury. It is estimated that 4 to 7% of the population over the age of 40 have an IOP greater than 21 millimeter mercury with the open filtration angle and without a detectable glaucomatous damage. These individuals are referred to as having an ocular hypertension. So greater than 70 years, 23 up till 23 millimeter mercury, the pressure is considered normal. So what is ocular hypertension? Is basically when IOP is greater than 21 millimeter mercury and there is no glaucomatous optic neuropathy and there are open angles, then it is known as ocular hypertension. Approximately 1 in 10 will develop glaucoma over a 10-year period, and the majority will not develop glaucoma in lifetime. So, the rate of developing glaucoma in a case of ocular hypertension is very low. So, the thing is, why we are so concerned about this is basically in a case of glaucoma, we want to detect the glaucoma early so that we can do preventive treatment as early as possible, so to decrease any optic neuropathy. So this is a 11.4. It is showing the distribution of IOP in general population. So the curve is skewed to right. So what are the risk factors for developing glaucoma in ocular hypertension? So there are some studies that has been done in a case of ocular hypertension and they are being followed. So there, so when the people who develop glaucoma in case of ocular hypertension will have a certain risk factors that will lead an increased chance of having them glaucoma. So, the ocular hypertension treatment study was a multi-center longitudinal trial. In addition to looking at the effect of treatment of individual with ocular hypertension, IOP in one eye between 24 millimeter mercury and 32 millimeter mercury, invaluable information was gained about the effect of the range of putative risk for conversion from ocular hypertension to glaucoma. The percentage of ocular hypertension patient likely to develop glaucoma at 6 year taking risk factors key factors into account is set out into table 11.1 and 11.2. So basically in ocular hypertension treatment study was done. Basically you start treating the cases of ocular hypertension and see that if they develop glaucoma or not. And the other thing is that basically they are checking the 6 year 6 year follow-up and seeing what are the risk factor that leads to patient development of glaucoma in patient of ocular hypertension. Limitations include the following. The study goal was an IOP reduction of 20%, which may not be sufficient in some individual. Compliance with medication was not measured, and there is a possibility that early glaucomatous damage was already present in some cases. So basically, in usually we do the IOP reduction in 33% in a case of a glaucoma, but in this study, the IOP reduction was done up to 20%, which was not sufficient to control the glaucoma. Next is that the compliance of medication was not measured, that if the patient is taking medication or not. So what were the conclusion based on the factors that were significant on the multivariant analysis? Intraocular pressure, the risk of developing glaucoma increases with increasing IOP. So it showed that a patient who already have a very high IOP, like for example more than 33, as compared to those who have an 24, are having an increased risk of having development of glaucoma. Older age is associated with greater risk. So those patients who are having a greater age will have an increased risk of developing glaucoma. Central corneal thickness, very important. The risk is greater in eyes with ocular hypertension and CCT less than 555 micrometer, and lower in eyes with a high CCT greater than 588 micrometer. This may be due to the under and overestimation of IOP, although it is more likely that associated structural factor, perhaps at the lamina cribrosa, might be involved. CCT can be determined using an optical imaging, for example ORT scan, or ultrasonography, for example pigment. So very important point of view, that basically it was determining the CCT ratio. So CCT is basically the central corneal thickness. And what is its effect on measurement of IOP? If we have a decrease CCT, it will show decrease IOP. If we have increased CCT, it will show increased IOP. So a patient who is having an ocular hypertension is having a decreased CCT, it means that a chances of having, because it will show less IOP as compared to the normal CCT. So the chances of having an ocular hypertension developing into glaucoma is higher as compared to that having a greater CCT of almost 588 micrometer. Cup disc ratio, the greater the CDR ratio, the higher the risk. There may be because an optic nerve head with a large cup is structurally more vulnerable, or it may be early damage is already present. So greater the CDR ratio, the greater the risk of developing glaucoma. Pattern standard deviation, the higher the PST value, the greater the risk. This possibly significant early glaucomatous field change. So we can see the risk of developing glaucoma according to IOP and CCT. So you can see if the mean IOP is greater than 25.75 micrometer millimeter, and if the CCT is less than 55, the chances are 36%. If the CCT is greater than 5555 to 588, it is 13%. And if it is greater than 588, it is 6%. Whereas in those having an IOP greater than 23 to 25 almost, it is having greater in having a lower CCT, then midway, and then 7% in with a greater CCT. And I mean IOP less than 23.75, you can see that those having an IOP greater than 25 had a higher rate of developing glaucoma, and those having a less than 23 has a lower risk of developing glaucoma, and those having a CCT less than 55 have a less chances of greater chances of developing glaucoma, whereas those having greater CCT have a less chances of developing glaucoma. So same is showing that a CDR ratio, the greater the CDR ratio and the less the CCT, will have a greater chances of having a development of glaucoma, whereas lesser the CCT and lower the greater the CCT, and lesser the CDR ratio, the lower the chances of having development of glaucoma. Conclusion: based on the factors that were significant on a univariate variate analysis only, these were overridden when the factors discussed above were considered. African ethnic backgrounds, including Afro-Caribbean, African American, is associated with higher glaucoma risk. Males are more likely to convert. Heart disease is a significant risk factor. So these are all other significant factors which can contribute to the development of glaucoma in case of ocular hypertension. Factors examined in ocular hypertension treatment studies were found to be insignificant. So these were some of the factors that was studied, but they were not found so much significant: myopia, diabetes, and family history of glaucoma. These have a role in open angle glaucoma, but in ocular hypertension they found to be insignificant. Myopia: although it is suspected that myopic discs are more susceptible to glaucomatous damage at a lower IOP than emetropic discs. Diabetes, family history of glaucoma, which is curious as patients with glaucoma often have a family history of disease. So what is the conclusion of the ocular hypertension treatment study? Early treatment reduces the cumulative incidence of glaucoma. Effect is greater in high risk individuals. Early treatment of low risk individual is not needed. Individualized assessment of the risk is useful and helpful to guide the management. So basically, what we concluded from the ocular hypertension studies is basically that treating a case of ocular hypertension has some benefit in preventing the patient into glaucoma, but not all the patients get treated get be prevented. So we will only treat patient based on the risk factors. So those having a risk factors like having a higher IOP, having a lesser CCT, having a greater age, we will likely to treat them, whereas those having a low risk factor, we will not treat them. So this is how you measurement of CCT with orb scan and pacment. So what are the genetics of the ocular hypertension? A single nucleotide polymorphism in a TMC01 appears to be significantly associated with conversion to glaucoma in white people with ocular hypertension. Threefold risk in individual with two risk alleles compared to those with no risk alleles. So there is a gene that is associated with it. So those having a mutation of this gene will have more likely that ocular hypertension will convert into glaucoma. A recent meta-analysis has identified 112 genetic loci associated with IOP and suggests a major role for angiopoietin receptor tyrosine kinase signaling, lipid metabolism, mitochondrial function, and developmental processes as a risk factor for elevated IOP. So, how will you clinically evaluate a patient with ocular hypertension? History and examination should be carried out as for glaucoma. Consideration should be given to whether any systemic medication is being taken that might be influencing IOP, either upwards steroid or downward beta blocker. So, if a patient is taking systemic medication, especially like if a patient is taking a beta blocker, it will tends to lower the IOP, whereas if a patient is taking steroid, it will causing the increase of IOP. A pre-perimetric glaucoma. So basically, pre-perimetric glaucoma is referred to the detection of glaucoma before that which occur in the visual fields. You know that glaucoma can lead to the visual fields changes, but our main concern is to detect the damage, glaucomatous damage, before it appear on the visual fields. So, pre-perimetric glaucoma, this concept refers to the glaucomatous damage usually manifested by a suspicious optic disc and a presence of a retinal nerve fiber layer defect in which no visual field abnormality has detected. So, we will have a suspicious optic disc and retinal nerve fiber damage that will occur before the visual field abnormality. So, these are all the pre-perimetric glaucoma. The field testing modality for this purpose is usually taken as a standard achromatic automated perimetry. So, how will you manage the case of ocular hypertension? Raised IOP is an important risk factor in the development of glaucoma and can be modified with treatment. So, the more the IOP is raised in a case of ocular hypertension, more you likely to get benefited from the treatment. However, it is difficult to justify the treatment of all individuals with raised IOP because of the high prevalence of the ocular hypertension, the low conversion rate to glaucoma, and the cost and the side effects of the treatment. So, you have to decide whether you want to treat the patients or not. I told you, based on the ocular hypertension treatment studies, we do not treat every glaucoma patient because it has only some benefits on those converted into glaucoma, but you tend to treat those who have a higher risk factors, like those having a very high IOP, those having age, those having a low CCT. So these are all the risk factors that will allow us to manage the patient with ocular hypertension. In the ocular hypertension treatment study, untreated patient with ocular hypertension has a 9.5% cumulative risk of developing primary open angle glaucoma after 5 years. Treatment which is aimed to reduce IOP by 20% or more to reach 24 millimeter mercury or less, reduce this to 4.4%. So usually the patient has a 9.5% risk of developing into glaucoma, but with treatment the risk was reduced to 4.4%, which was not very kind of significant. So, validated prediction model using the ocular parameters of a given individual with ocular hypertension allow the 5-year risk of glaucoma, developing glaucoma, to be estimated and expressed as a percentage. So, you can predict that how much risk a patient with ocular hypertension have to develop a glaucoma. This helps in deciding on the frequency of testing and whether to start treatment. In general, only those high risk should be treated, although patient preference may be a decisive factor, and age and therefore life expectancy is a key point to consider. Most practitioners would treat every patient with an IOP of 30 millimeter mercury or more for greater than 40% 5 year risk of glaucoma. So I told you earlier that if a patient is having a high risk factors, then you tends to treat them with ocular hypertension. Otherwise, there is no need to treat them with the ocular hypertension. So generally, the practitioner, those patients who have a IOP of greater than 30 millimeter mercury, we tends to treat them because they have a more chance of developing into glaucoma. This decision to treat in patient with varying risk profile is not straightforward and has to be made on individual basis. Ocular hypertension increases the risk of retinal venous occlusion, an additional point to consider when deciding whether to start treatment. Because IOP is a risk factor for developing glaucoma, so one should, venous occlusion CRVO. So one should always consider that if a patient is constantly having a high IOP, they will have an increased risk of having a CRVO. Treatment options are the same as for POG, although a less aggressive pressure lowering approach is frequently taken. Careful monitoring is a reasonable alternative in many circumstances. Baseline visual field and retinal fiber layer disc imaging should be performed. So sometimes the we all just do observation, we do the baseline investigation, and then ask the patient to follow up. So that's it for the glaucoma part 2. See you in the next lecture.